I'm going to start this video by showing two cases that Antonina Kalmykova of CSD Healthcare in Kiev has kindly shared with me. And when we've looked at them, I'll have a short presentation on Desmoplastic nevi. So here's the first case. I don't have any clinical information, but we'll just have to make do without it. Now, there are 6 pieces of tissue on the slide, which I've looked at, and this bottom one is probably the most representative, so we're going to focus on that. So I'll just straighten it up. Unfortunately, it's a partial cut, so we're missing a little bit of the lesion, but I don't think that matters too much. So when we look at it at low power, we can see that there's a sort of a plaque-like growth occupying the superficial dermis, and there's some acanthosis and a bit of hyperpigmentation along the basal layer of the epidermis, and we can see that there are melanophages scattered around the superficial dermis. So we'll have a closer look at that now and see what's actually going on. Well, there are a few things that we can notice. The first is that we're beginning to see there's a little bit of junctional activity there and perhaps there and there. So this lesion involves both the epidermis and the dermis. We'll look at that a bit more closely, and we can see, in fact, that there are multiple junctional nests. They're surrounded by a very conspicuous retraction artifact, and the cells forming the nests in the junctional and the superficial component are very discohesive. And so this is very, very Spitzoid. But if we sort of take a look at the whole lesion, we can see that there's some variation in the size of the nests and the size of the cells when we look at the top of the lesion until we look down in the bottom. And that's pretty conspicuous all the way across. And the other thing you can notice, this is just quite a nice view to look at it. You get the feeling that there's a V shape, and there's the edge there of the V if I follow with the arrow. So we get the sense that this is a pyramidal lesion, and we'll look at it again in low power in a moment or two to check that out further. So let's see what the lesion's composed of. And well, it's really very, very nice indeed. It's very much a Spitz nevus, or a Spitzoid proliferation, perhaps I should say at this point, with nests of spindle cells superficially and in the middle. And as one gets deeper down, the morphology becomes much more epithelioid. So let's look at that in high power and see what we can pick up extra. Well, there are lots of pigmented dendritic cells, largely melanophages, I suppose. There are these Spitzoid spindle cells with abundant cytoplasm, large nuclei. But then as we go deeper in, you can start to see the cell morphology changes, and they become much more epithelioid, again with abundant cytoplasm, vesicular nuclei with a small but prominent nucleolus. And there's an interesting little feature right in the center. You can see that there's a cytoplasmic pseudo-inclusion in the middle of that nucleus. And if I go up to the top, there's another one there. And in fact, they're quite conspicuous. So I'm moving down towards the base of the lesion, and you can see that this population is much less much less conspicuous. The cells are certainly smaller. And so I think we can say with a degree of confidence that there's good maturation. There's a nice field there. There's one pseudo-inclusion. There's another one. There's another one. There are two in that nucleus. There's one there. There's one there. In fact, they're all over the place. And these are very typically seen in Desmoplastic Spitz nevus, and they're not of any importance other than if they're really conspicuous and you're not thinking along a Spitz nevus pathway. Let's say your mind has gone off in some other direction, you might be wondering about a signet ring cell carcinoma or something of that nature. Now I'm just going to go back down to the ×2. No, I don't think we can really go for a pyramidal shaped lesion on the low power. It's terribly flat, but that doesn't matter. Some Spitz nevi are pyramidal with the base uppermost, and some of them are rather flat, and I suppose this one falls into that category. We'll just have a quick squint. Maybe I'll go back to this low power. We'll just check out this top one and see if there's anything that we're missing. It's a lot better stained, which I suppose is a major plus. We'll just straighten it again. And just to remind you, when you're taking photographs, if you can do what I've just done and straighten the top up so the epidermis is parallel with the edge of the screen, it would be very helpful. It makes it much easier to look at. And I think even at this magnification, we can see it pretty much the same thing. So my conclusion on this, well, by the way, I've looked everywhere and there's not a mitosis to be found. So my conclusion on this case is this is a Desmoplastic Spitz nevus. Now I'm going to close that window and I'm going to look at another case a bit more speedily, but just so that we've looked at two. Now there are two slides. These two bits of tissue show a scar, so it's been previously biopsied, and this is the lesion in the second slide, and it's really rather nice. I'm going to do something just before I forget. I'm going to take a photograph of this because I want to show you something that you can do to improve contrast to help you look at a lesion more easily. So I'll move that to my desktop. There we are. So I'll move that, close that, and get back to the image. And I'll have a look at that in Photoshop shortly. But this is quite nice because we can see that there's a lesion which extends from the papillary dermis down into the reticular dermis. In this area, it's following down a follicle, and this bit, well, we don't know what it's following down. So it's a sort of a roughly pyramidal shaped lesion. There's one side, there's the other, and there's the base along the top. So the growth pattern at low power is a source of comfort because malignant lesions don't really tend to sort of adopt that pattern. So let's look at it at a bit higher magnification and see what we can make out in this lesion. Well, it's showing lentiginous hyperplasia, I suppose, of the epidermis, and there are certainly increased numbers of melanocytes, but I'm not sure whether there are any junctional nests or not. But then we look in the superficial dermis, and there's lots and lots of pigment-laden macrophages or melanophages, and then there's this infiltrate, and then as we go deeper, there's tremendous desmoplastic stroma and very small nuclei scattered around. So one's thinking along with this lesion is this is probably going to turn out to be a desmoplastic. Well, it's either a desmoplastic nevus, or I suppose conceivably it could be a desmoplastic melanoma. Those would be my two differentials at this point. So let's see what a higher power view shows us. And we can see, well, there's no evidence of a worrying intraepidermal component. That's the first thing that we need to identify. So we don't see in situ melanoma. There's a little bit of junction activity there, so there is a touch of it. But most desmoplastic melanomas arise in a background of lentigo maligna or lentigo maligna melanoma, and we're not seeing that in this epidermis. So that's a bit of good news. We'll just magnify it up now and see what we can make out. There's a high power view. So we've got lots and lots of smallish cells, some rather spindly, some a bit more epithelioid, with abundant cytoplasm. The nuclei, yes, I think they are mildly pleomorphic, but there are no really prominent nuclei. Now, I know also that this one doesn't show any mitoses, so that's something we needn't worry about at the moment. And let's see what it shows at the base. Well, this is, you see, this is the bit of the lesion that we need to be looking at really, because this is telling us this is the desmoplastic part. And it's composed of smallish cells. They're epithelioid, they have round or oval nuclei with small nuclei, and they certainly get smaller the deeper you go. So I think this thing's showing good maturation. There's no perineural infiltration. So I think on balance again with this, I would think this is a desmoplastic nevus. Now whether it's a desmoplastic Spitz nevus is another matter. We haven't really. I mean, it probably is, but let's just, well, maybe go down one magnification. Let's see if we can see anything that says, you know, I am Spitz, and that's all there is to it. Well, I suppose that those sort of nuclei there, let's look at that a bit higher magnification. I suppose cells like that, those multinucleate cells, and that cell there with an awful lot of cytoplasm, I suppose we could twist my arm and say, well, I think this is Spitzoid. So if that was the case, then we'd have to call this a desmoplastic Spitz nevus. Now, to be honest with you, it doesn't matter tuppence whether it's a desmoplastic Spitz nevus or just a desmoplastic nevus. The important thing is it matures with depth and is benign. So I'm going to come out of this program now, and I'm going to show you something else before talking about the entity. I want to show you that image that the photograph I took. So we're going to open that with Photoshop, excuse me, and I'm going to enlarge it just so that we can see it a bit more readily. Now it's a lovely photograph. It's beautifully focused. It's nice color, but I think we can make it better. And the reason I want to make it better is just to demonstrate to you how you can make out the silhouette better by playing with the image a little bit. So the first thing one does with every image, no matter what it is you go to image, wait a minute, I have to just cancel that crop. I don't necessarily want to crop it. So let's go to the image. We'll go to adjustments and go down to the second one, which is levels. And if you go across to the levels box, if you click on the far right, and then use that dropper and put it near to the specimen where you think it's not as white as it should be. Actually, this looks awfully good, so it probably won't do anything, but still, we'll do it anyway. So there we've clicked on it, nothing has happened, so that means that the white balance in this case was perfect. Now then, the next thing we can do is we want to try and see if we can't make the contrast better. So again, go to Image, and then take the fourth down which says Auto Contrast, and click on that and see what happens. And well, it's certainly brought up the contrast, but the color is hideous, so I don't like that one bit, so we'll get rid of that. So you go to Edit and undo Auto Contrast, and we're back where we are. So the next thing you can try doing is go to Image, go to Adjustments, and come down to Shadows and Highlights, and click on that, and the second item in that box is highlights, and you can just increase the amount of highlights a bit and see what happens. Now I think that's looking a little bit better, so we'll click OK on that, but I still don't like the color very much, so I'm going to play with that a little bit just for fun. And the easiest thing to do is go to hue and saturation. If we increase the saturation, I think that's beginning to look a lot nicer, and we might bring up the, take away some of the blue and just leave it at, if we leave it like that for the moment. Now what the effect that I've achieved by doing this is I've made the outline of the lesion a little bit more obvious, and I think one can get a better impression of, there's a V going down there, and there's a V coming across there. So that confirms that there is a silhouette that is wedge-shaped with the base uppermost, and this, I think, is very much in favor of a benign lesion. So we'll close that now, and whoops, hang on, I've got to cancel crop. There are lots of little things you have to remember with Photoshop, or you get yourself into trouble. So we'll close Photoshop, and then very finally I want to open up this short PowerPoint presentation, and we'll look at it as a slideshow and play from the start. And so I want to talk briefly about Desmoplastic nevus, particularly Desmoplastic Spitz nevus. Now, this is, I don't know how common it is really, because when you talk about incidence, what you're really saying is the incidence that one encounters in patients who go to the doctor in the first place. But we don't know how many patients who have it who don't go to the doctor, so we don't know really what the incidence in the general population is at all. But if we do it another way around and say, how often does one encounter this? I would say one encounters this very uncommonly. It's certainly it's something that always pleases you when you see one. So, Desmoplastic Spitz nevus is a variant of Spitz nevus characterized by desmoplasia in the underlying dermis. And like Spitz nevi, it can present as a papule or a nodule, which may be a little bit crusted, and it may be either red or brown or a mixture of the two in color. And most of these lesions appear to grow on the limbs. I'm not sure why, but that's where we tend to see them. And there's a bit of a predilection for females. And I think you can see these at a wide age range, from children well up into middle age, but they're most common in the third decade. And I must remember to thank Primary Care Dermatological Society for this image, which I borrowed. Now, the histology of Desmoplastic Spitz nevus, well, I've shown you two examples, and they're lovely examples, so I think by now you've a good idea of what they look like anyway. But just to remind you, they may be compound or they may be intradermal. They tend to have a wedge-shaped growth pattern, but not always, as we saw with particularly with the first case. We tend to say Desmoplastic Spitz nevi are composed of epithelioid cells, and that by and large is true, but as you've seen now, it may also contain spindle forms as well, so they're often a mixture of the two. I highlighted the intranuclear pseudo-inclusions and the maturation with depth. Now, there are some publications which say that occasionally you may get mitotic figures in these lesions, particularly in the older folk. Well, that may well be the case, but it hasn't been my experience. But anyway, so I think that's an open question. Now, the interesting thing is, for those of you who like to do immunohistochemistry, if you do P16, it's very nicely, strongly positive from top to bottom. And we know that at the molecular level, this is associated with HRAS mutation and increased copy numbers of 11p. So this is the case that we started off with, and you can see in this example there are mostly epithelioid cells with abundant cytoplasm, vesicular nuclei, and prominent nucleoli, and they're very uniform. It's a very monotonous population, and there it is in higher power there. And here we see the superficial part of the lesion. Now, if you took this field on its own and you didn't have anything else, with this pigment, you'd probably think this was a melanoma, and I wouldn't blame you. So you need to make sure that you've seen all of a lesion before you come to a diagnosis. I think the next slide is the deep part. Yes, it is. There's the depth of the lesion, and you can see the cells are considerably smaller. The nuclei are smaller, so there's good maturation with depth. And here's an S100 protein. I used to do this quite a lot, not to confirm the lineage of the cell type, because I think that's pretty obvious. What it is very useful, and melan A would be just as good if you like, is that the S100 protein, it emphasizes the size of the nests and the cells at the top and to compare them with the bottom. So it's a much easier way of assessing maturation with depth. So that's why I've used it. And here's another one. This is a beautiful example. You can see on the left, there's a multinucleate giant cell that we see over here. So, but this is a dermal example, and you can see the cell size is clearly getting smaller with depth. There's a lot of collagens, there's a lot of sclerosis, so this is very desmoplastic. And there's a high power of this area here and on this side showing you these very spitzoid multinucleate giant cells. And here I'm not quite sure where these come from, but I put these in just to highlight the pseudo inclusions again. And lastly, we'll just talk about differential diagnosis. To my mind, the entity that's most easily confused with a Desmoplastic Spitz is the epithelioid cell fibrous histiocytoma, and I'll show you one in a moment. Desmoplastic melanoma is really composed of hyperchromatic spindle cells, and nearly always shows lentigo maligna on top and perineural infiltration within the lesion. But I'll show you an example of that in a minute too. I mentioned metastatic carcinoma, but I think it would be very hard pushed to come up with that one. Spitzoid melanoma. Well, a spitzoid melanoma, in reality, at least to my mind, I only use that term if I'm looking at something that's clearly malignant without giving it a second's thought. It's malignant, but it's got some vaguely spitzoid appearances near the top. And so that doesn't really come into the differential either. So here's a lovely epithelioid cell fibrous histiocytoma, which Carlos very kindly shared on McKee a while ago. And on the right, we have the ALK expression. And it's very nice because not only is it positive, but it shows you the density of the infiltrate. Now, if you compare this with the Desmoplastic Spitz, there is no desmoplasia in the epithelioid cell fibrous histiocytoma. It's just millions of epithelioid cells. Sometimes one can see an epidermal collarette around these lesions, which is a very characteristic feature, but you don't always see it. Excuse me, you don't see spindle cells in epithelioid cell fibrous histiocytoma. I suppose that's almost a definitional thing, isn't it, really? And mitosis are very sparse. And nowadays we know these tumors express ALK, so that makes life very easy. And here's the same lesion showing you medium and higher power, densely cellular, very monotonous infiltrate. And there's the high power view there showing these. Now this view on its own, I think you could mistake for a Desmoplastic Spitz because there is a bit of collagen here or there. So that would be a reasonable differential. Now, here's desmoplastic melanoma, and as I mentioned, these nearly always arise on sun-damaged skin in the elderly patient, usually against a background of a pre-existent lentigo malignus. So there's this huge, irregular, variably pigmented lesion with dark and pale brown areas, and there's a nodule there, which is going to be the invasive tumor. At least that's going to be at least part of the invasive tumor. And this is, if you like, the textbook desmoplastic melanoma histology. You can see the clue. One of the clues are these huge lymphoid aggregates. If you have a melanocytic lesion with those, well, woe betide if you start thinking of benign. Start thinking of malignant until you can prove it isn't, which won't really happen, I don't think. But anyway, you can see that there are spindle cells and there's this intense desmoplastic stroma. And if we look at, there's the surface, and you can see there's junctional, excuse me, activity, and a lentiginous hyperplasia. And there's the bottom of the lesion with hyperchromatic spindle cells deep in the reticulodermis and going down into the fat, as you see there. And here's some high power fields showing very hyperchromatic nuclei and some very marked nuclear pleomorphism. So that's a desmoplastic melanoma. Sorry. And as I mentioned, desmoplastic melanoma nearly always shows neurotropism. So here's some nerve fibers infiltrated by clearly malignant tumor cells. This is all the same case. And lastly, I just wanted to draw your attention that Desmoplastic Spitz is not the only lesion, benign lesion, that may show desmoplasia. You can see desmoplasia in a banal nevus, and you can see desmoplastic change in a combined nevus. I rather think this might be a combined blue and banal nevus, with this deep stuff being sort of defunct type B cells. Well, I hope that's. Oh, here's the last picture. I forgot about this one. This is a very nice desmoplastic or sclerosing blue nevus with the high power view showing dendritic cells on the right. And I think that's the end. So I hope this has been of some use to you, and that you've enjoyed it. So thank you very much for your attention.